and all. The topic is dissecting OSA, the role of endotypes and phenotypes in precision medicine. As we all know, obstructive sleep apnea can be classified as mild, moderate, and severe based on the apnea-hypopnea index. So, mild means 5 to 15, moderate 6 to 16 to 30, and severe is greater than 30. But nowadays, the classification it's on the changing trend. We classify not only based mere on the apnea-hypopnea index, but also we take in account of the symptoms and the organ impact. So the classification known as the Baveno classification is the new classification where we take in account of the symptoms and organ damage. Where we take the symptoms on the x-axis and the organ damage on the y-axis, we classify as A, B, C and D, A with minimal symptoms, D severe symptoms. So, obstructive sleep apnea is a heterogeneous syndrome with varied predisposing factors, pathophysical mechanisms, and clinical presentations, consequences of respiratory events. The current algorithm of treatment which is being followed, you diagnose a patient with OSA, you advise CPAP. If the patient is not using CPAP, look for other treatment. But what's happening? The patients with the same AHI, they respond differently to the same treatment. For example, if you give CPAP to 5 OSA patients, all 5 patients will respond differently to AHI or to the CPAP. If you prescribe surgery to all the 5 patients, all the 5 patients will respond differently to the treatment. So why different responses to the same treatment? The reason being heterogeneous pathology with multiple possible causes. So understanding the pathophysiology is the key, and Eckert et al. Describes 4 phenotypes or endotypes. So what is an endotype? The underlying pathophysiological process or mechanisms derived through sleep study is the endotype, and the manifestation is the phenotype. So what are the 4 important phenotypes or the endotypes described along with OSA? So first is foremost the upper airway collapsibility. Second is the ventilatory control of the loop gain. Third is the muscle factor. Fourth is the arousal threshold, where the upper airway collapsibility can be considered both physiological as well as anatomical. As you all know, patients with obesity and supine position, there is a higher tendency to collapsible airway, and though OSA is predominantly common in males compared to females, gender doesn't seem to influence upper airway collapse. So the most important another factor is the ventilatory stability or loop gain. So what actually happens? In a OSA patient, whenever there is an obstructive event, that leads to hyperventilation, which in turn leads to decreased PaCO2, which in turn leads to excessive response, and the entire ventilation process will go for a jeopardy, what we call it as the ventilatory instability or the loop gain. So what is the muscle response? As you all know, there are different pharyngeal muscles responsible to keep the pharyngeal airway intact. So genioglossus is the primary dilator. Tensor veli palatine and other pharyngeal musculature, they all act to keep the airway intact. But among the muscles, different muscles react in a different way. For example, a muscle which has a good dilation property, but it responses poor to the obstruction, will not be helpful in maintaining the airway. Whereas the muscle is having a good response to obstruction, but the poor dilation effect will lead to a decrease in the effect of OSA. So in OSA patients, it's been found out that type 2A fibers are predominant. Type 2A fibers are in general, they have little resistance to hypoxia. In turn, their response will be poor. Fourth is the arousal threshold. So what do you mean by arousal threshold? There will be patients with OSA, but if you see across, there will be frequent awakenings during night. So there will be sleep fragmentation, and which in turn will leads to poor sleep quality. Whereas a high arousal threshold is protective of upper airways patency. For patients with post-traumatic stress disorder, there will be frequent awakenings in the night. So for those patients, if you are going to advise surgery means, then the patients will be a failure. So how do we measure? All these important endotypes have been gold standard techniques which cannot be implemented clinically. So how can we implement all those endotypes clinically? So as you all know, upper airway collapsibility we determine with the help of critical airway pressure, which can be obtained from a CPAP trial. And other obesity and craniofacial abnormalities and CPAP pressure levels we can easily attain from clinically. So low arousal threshold. Whenever you come across a patient with OSA in the sleep study, the AHI is less than 30, nadir means lowest desaturation is greater than 82.5, and there are more hypopneas than apneas, then you should suspect that patient might be having a low arousal threshold. And loop gain, as you all know, as I said, all those PaCO2, ventilator instability, all theoretical concepts. So how do we implement in a clinical setup? So with the help of nasal pressure signals in PSG data, and if there is more percentage of apneas in the sleep study, then we should suspect high loop gain. In high loop gain, CPAP in general will not be as effective. So what is the muscle response? Again, we can identify the muscle response using nasal pressure signals. And in case of sleep stages, if REM predominant OSA, patient will be having a good muscle response than compared to an NREM OSA. So the entire presentation can be summed up with one presentation. Can you all, if you see, means the above will be the all the endotypes. The y-axis will be the treatment options. If you see, as you all know, gold standard treatment for OSA is CPAP. But if you see patients with poor loop gain and poor muscle responsiveness, and if there is some pattern of collapse like an epiglottic collapse, CPAP will not be effective at all. Whereas again, mandibular advancement device, if the patient is having a low arousal threshold or the poor muscle response, mandibular advancement device will not work. Hypoglossal nerve stimulation, again in high loop gain and poor muscle response, it will not work. Most importantly, the upper airway surgery, as I mentioned, if you do surgery for a patient with a low arousal threshold, you might be having to consider that post-op you have to give some sedative hypnotics to overcome the arousal threshold. Drug therapy, we always believe that there is no drug therapy for OSA, but if you see that drug therapy also plays an important role in the management of OSA. So just a brief note on the pharmacological therapy. As I said, that high loop gain is a negative factor for CPAP trial. So in patients who are no other options except CPAP trial, but they having a loop gain, if you give acetazolamide in your treatment, patient might, the CPAP compliance might increase. Whereas the spironolactone, it will improve the upper airway by reducing the fluid retention and edema. As I said, low arousal threshold, we also always consider zopiclone or the zolpidem group of drugs for low arousal threshold. And in case of again high loop gain, along with drug therapy, if you consider oxygen therapy, the patient might be having a better CPAP compliance. And one of the recent advances in pharmacotherapy is the atomoxetine and the oxybutynin drug is one of the most promising therapy. It's been shown that it plays a very important role in improving the airway, and it will decrease the loop gain, and improves the muscle response. But only thing is, it might lower the arousal threshold. So conclusion, as I said, OSA is multifactorial. The pathophysiology reveals different endotypes. Different endotypes respond differently to different treatment options. One size fit all will not work in OSA management, and future beckons management of OSA based on phenotypes and endotypes. Thank you. We have to consider both, sir. In case of Down syndrome, we should take in account of the craniofacial abnormalities as well as the muscle response. In those cases, when we have corrected the anatomical discrepancies, and still if you feel that the child is having or the patient is having a OSA, that time if you do a level 1 or the level 2 sleep study, from those data, we can somehow come to a conclusion that there will be a muscle factor also, sir.
Have such children come to you?
Sir?
Have such children come
right
to
now, till now, Down syndrome not, sir, but patients with mucopolysaccharidosis, we have operated just 2 months back. Patient was having a typical craniofacial abnormalities with a huge tongue, and there is a collapsible airway. So as of now, we have did a adenotonsillectomy, but we advise the patient that future the child might be having multiple interventions in order to have a
age of that child?
4 years, 3.5 years.
Thank you.
Thank you, sir.